Hello everyone, my name is Rahul Tuli and I'm a fourth-year medical student at the University of California, Riverside School of Medicine. I would like to thank the MOAS team for the opportunity to present our case report, From Gallbladder to Axilla, the unexpected path and presentation of adenosquamous gallbladder cancer. This case highlights an unusual metastatic pattern of a rare and aggressive malignancy with significant implications for prognosis, diagnosis, and treatment. Adenosquamous gallbladder carcinoma, also known as ASGC, is a rare and aggressive malignancy, comprising only 1 to 5% of all gallbladder cancers. It is more aggressive than pure adenocarcinoma due to its biphasic nature, containing both glandular and squamous components. ASGC typically metastasizes to the liver, lymph nodes, and peritoneum, but cutaneous metastases are exceptionally rare and signal advanced disease with a poor prognosis. Our patient is a 54-year-old female with hypertension and CKD3 secondary to IgA nephropathy, who presented to her primary care clinic with a progressive, enlarging, painful left axillary mass for 5 months. An initial ultrasound at an outside hospital revealed a solid suspicious mass classified as BI-RADS category 4. A subsequent biopsy of the left axillary mass showed metastatic squamous cell carcinoma of unknown primary origin, positive for CK56, CK7, P16, and P63. She was then referred to a hematology oncology clinic. Three weeks later, before her oncology appointment, she presented to the emergency department with right upper quadrant pain, nausea, and vomiting. Lab results were largely unremarkable, showing only mild elevations in AST, ALT, and ALK-Phos, but normal white blood cell count and total bilirubin. Ultrasound revealed a distended gallbladder, which was greater than 12 centimeters, extensive cholelithiasis, mild gallbladder wall thickening, pericholecystic fluid, and a dilated common bile duct that was greater than 8 millimeters. Sonographic Murphy sign was negative. CT abdomen and pelvis with contrast and MRI MRCP confirmed these findings but showed no common bile duct obstruction, ruling out choledocholithiasis. She was admitted for acute cholecystitis and underwent laparoscopic cholecystectomy. Intraoperatively, the gallbladder was grossly distended, thickened, and inflamed, with spillage of hydrops and mucin during the procedure. She was discharged postoperatively without complications. Histopathology of the gallbladder revealed poorly differentiated ASGC with lymphovascular invasion, positive for P63 and CK56, as well as positive liver margins without direct invasion, suggesting that axillary metastasis originated from the primary gallbladder ASGC. A PET-CT demonstrated hypermetabolic activity in the left axilla and periportal adenopathy, confirming metastatic disease. The patient was started on durvalumab, gemcitabine, and cisplatin. However, despite chemotherapy, her disease continued to progress on imaging and clinical examination. Before second-line therapy could be initiated, her ECOG deteriorated to 3/4, and she was transitioned to hospice care. Cutaneous metastases from internal malignancies occur in approximately 5% of cases, with even lower rates in gallbladder cancers. Interestingly, in ASGC, the squamous component exhibits a higher proliferative index compared to adenocarcinoma, as demonstrated by Ki67 staining, which may contribute to its aggressive nature and unusual metastatic behavior. One proposed mechanism of ASGC metastatic spread includes retrograde lymphatic permeation, whereby tumor cells bypass conventional hepatoduodenal lymph nodes via intercostal lymphatic and thoracoepigastric anastomoses. Another hypothesis is that ASGC squamous component shows preferential expression of cutaneous receptors. Advanced ASGC carries an extremely poor prognosis with a less than 5% 5-year survival rate. The presence of cutaneous metastases signals widespread disease and poor outcomes. Theories of pathogenesis suggest chronic inflammation drives metaplastic transformation and stem cell plasticity, contributing to ASGC's aggressiveness. PET-CT is superior to conventional imaging for detecting metastases, especially cutaneous lesions often missed on standard contrast-enhanced CT. Surgical resection is the mainstay of treatment for early-stage disease. For advanced disease, surgery and adjuvant chemotherapy with gemcitabine, cisplatin, and immune checkpoint inhibitors offer some benefit. Literature suggests that ASGC may express higher PD-L1 levels than adenocarcinoma, similar to adenosquamous lung cancer, making it a potential candidate for immunotherapy. However, for this patient, neogenomic workup did not show any targetable mutations. Liquid biopsies are an emerging development in cancer research that may hold promise for analyzing circulating tumor DNA, and exosomal microRNA profiling may serve as non-invasive methods for early metastatic detection. For patients with ASGC, further research is essential to optimize treatment and improve outcomes, especially considering its rare but aggressive nature. To conclude, this case underscores the highly aggressive nature of ASGC and highlights an uncommon metastatic pattern. Our findings emphasize the need for early detection and accurate staging with PET-CT in order to guide treatment and exploration of immunotherapy as a viable treatment option in ASGC. Thank you all again for this opportunity.